Good morning, everyone. We're going to go ahead and get started. I want to know first if I need the mic because there is a little bit of background noise. Are we okay just speaking this way? Can everybody hear me?
Yeah.
Way better? Yeah. Okay, great. That way we don't have to worry about getting tangled in this. So first of all, welcome and thank you so much everyone for attending our White Coat Press briefing. The purpose of us putting this event together primarily is to recognize the fact that we are concerned healthcare advocates about what's going on in healthcare in America, particularly in Orange County for relevancy for us. We are representing the community health centers in Orange County. We are a consortium that represents 26 community health center entities in the county, and they operate 71 sites throughout the region. They provide care to over 330,000 patients per year to the tune of over 1 million visits, including primary, medical, dental, behavioral health, optometry, women's health, health education services, substance abuse, and the list goes on and on. Particularly in the last 5 years, there's been an expansion of sites that have expanded as a result, specifically of the Affordable Care Act and the additional funding that came with that act for community health centers specifically. So we are wanting to for the past, we've been around for 40 years, and the health centers have traditionally been known as the places of last resort. You go there only if you absolutely have to. We know that that's not the case. We've been trying to overturn that myth and wanting to make sure that the health centers are known for being providers of choice. And it's been since the last 5 years that we've been able to show and document that. For example, prior to the Affordable Care Act, in our county, being that there is no county hospital, we had a program called the Medical Services Initiative, or MSI, and over 100,000 individuals were in that program, and those individuals all transitioned into Medi-Cal. And the assumption was that the minute that those patients got coverage, they were going to run for the hills away from the clinics, and quite the opposite happened. All of them, 100%, stayed at the health centers, and all were converted, obviously, into Medicaid-covered lives, allowing the health centers increased sustainability and ability to grow and continue to expand. I have, obviously, a lot of investment, passion, and really desire to go into a real deep dive into how this has impacted the community health centers, but I can't do that alone. And all over during our spring, we have been doing advocacy efforts with our elected officials, both at the state and federal level, but most importantly with our federal representatives, because they are the decision makers at this point in terms of what happens with healthcare. And as we have found, we are the healthcare advocates, we're the paid talking heads. Of course, we're going to say what we say. They want to hear from providers. They want to hear from the patients. They want to hear from their constituents. They want to hear from people that are directly being impacted by either the expansions or the cuts and whatnot, and by the individuals that are seeing firsthand what the impacts are. So I am privileged to be in the company of great colleagues, great key stakeholders that are going to share with us their perspective from their specific lens in the healthcare industry that they represent. What we're going to do is I'm going to tell you who they all are ahead of time. Then we're going to pass on the mic, if you will, to each one. And then each one will then introduce the next person and so on. We will have about 3 to 5 minutes each, and we'll then open it up for questions after the session is over. I want to first, before I do that, really thank the staff. You guys did an amazing job. I really just had to show up and do my thing. You guys did it all. I really want to recognize the staff for the hard work that they did. And I also wish I could recognize every single person in here, but we'll stay on and on. But I do want to recognize any of our board members that are here. Please stand. I know Craig, our president, is here from the board. Directors, and I'm going to say that anybody traveling from outside of the county, I really want to thank you guys for making the special trip. I know Alan Gordon is here from Los Angeles, but also an Orange County resident. And then Dr. Jessica Detroit, yeah, from Thank you. Thank you so much for coming from outside the county. I know there's other folks that came from outside the county, so just wave and say hello. Thank you so much for everyone making the trek up here. So I'll tell you who's on our panel. I'm going to go back. We have Dr. Jose Mayorga, who's currently medical officer for Healthcare Partners at IPA in our county. But previous to that, he was the chief medical officer at Share Ourselves Community Health Center, or SOS. After that, we'll have Dr. Marco Angulo, who is the chief medical officer at Serve the People Health Center in Santa Ana. Previous to that, he was at UCI Family Health Center. And there's a lot of previous to that, but I'll only go the previous to the first title. Now, next to Dr. Angulo is Anders Wallen. He is a first-year medical student at UCI. He'll be addressing workforce issues for us. I'm going to go back a little to Dr. Mayorga and Dr. Angulo. They're both going to be talking about the value of the ACA. Next to him is Dr. Lynn Hunt, who is a physician at UCI Family Health, UCI as well. I don't know if it's at the clinic or
Family Health Center.
Family Health Center, great. And Dr. Hunt will be speaking on the importance of Medicaid funding for our health centers. Next to her is Matt Gentili, who is with the Centers for Inherited Blood Disorders. They are also one of our member health centers, and he'll be talking also about the importance of Medicaid funding and also the 340B drug pricing program that is a benefit of federally qualified health centers. And then we have Graham Danileco, who is a PA at the, and professor and director of the PA Chapman School at Chapman University. And he'll be obviously talking to us about workforce issues and the importance of maintaining critical funding streams for those programs, specifically for community health centers. With him is also Vivian Acevedo, who is a PA student as well at Chapman University PA School. Then we're going to skip Dr. Bell, because Dr. Bell will be providing closing remarks. And we're going to go to Fernando Hull, who is a PA at Central City Family Health Center, who's also a member of the coalition. And in closing, we'll have Dr. Bell and I share a few moments to do some closing remarks for you all. So without further ado, I'm going to turn over the space to Dr. Mayorga.
Thanks, Isabel. Thanks. Can everyone hear me okay in the back? Okay, fantastic. You know, first of all, thank you again for inviting me to speak. One of the things that I'd be remiss without saying is I could see some short coats in the audience, which makes me very excited to see. And the reason why, because I know some of you are students. And I think I have to say this because I know it'll be spoken about a little later, but without you, without the pipeline, we can't continue to take care of our community. So 2020 is a big year for healthcare in general. Unfortunately, that's the year that it's predicted that we're going to be about 50,000 PCP short. So that's a huge impact to our entire nation and of course here in Orange County. So thank you for taking the charge. Thank you for being committed and bringing the energy and the passion that all of us want to see in bright, exciting people to provide health care to the community, including ourselves. We need those clinicians, so thank you. You know, I'm a board certified family physician. My prior life was in the community health center setting. I've always been committed with the medically underserved. And what was interesting to me was, I apologize that I'm not wearing a white coat. And I jokingly say it's because my white coats are dirty and old, and I haven't had the luxury of cleaning them because I haven't been able to see a patient recently. But what I can share with you is the opportunity I've had being recruited away from SOS to work for a very large organization that's committed to serving all populations. And in order to do that, they felt the need that it was important to care for the medically underserved. So I now work for DaVita Healthcare Partners. And in my role, I actually partner with various groups, private offices, private practitioners, the private sector, as well as community health centers. And one of the things that was very unique when I first arrived, they felt I had a good insight to the community health center setting, those medically underserved patients. And so, granted, that knowledge lent me some insight, but more and more as I continue to work with my partners, in the community, I noticed such a huge need for our health centers more than anything else, than any other practitioners out there. And so one of the things that I want to share with you is from the perspective of the increase in patients, from my perspective, very high level, the immense amount of patients that came in through the ACA was very impactful. It's impactful to our organization because we literally doubled from one year to the next. And we needed to figure out how these patients were going to be cared for. For the first time, they had access to care. They had access to care to manage their chronic conditions that have been cared for. And more importantly, as a family doc, they had access to preventative care. And so those things are really critical. One of the things that we identified quickly was, yes, the opportunity for preventative care is so important. So those things such as, vaccinations, screenings, such as for mammograms, cervical cancer, were so important. We needed to find the right partners to do so. And so my prior life, I knew that our community health centers do a great job of managing these patients. And I know that because of the quality metrics that I review, to the patient experience things that I see. And at the end of the day, our organization is committed to working with them very intimately. And one of the things that I've been working with Isabel on is how do we actually continue to consolidate our efforts and actually drive the performance that is needed to manage a very, very difficult population. And so we're excited to partner with the coalition. We're excited to partner with our community health centers because truly they deliver the care that's needed from a preventative health care standpoint, as well as a chronic condition management.
So we are now transitioning on to Dr. Angulo.
I'm always following him. Dr. Mayo got recruited me to medical school, so that's why a big reason why I chose UC Irvine and to come to Orange County. But my name is Dr. Marco Angulo, and I'm the Chief Medical Officer of a federally qualified health center in Santa Ana called Serve the People. The most amazing, cutest clinic you've ever laid your eyes on. I love the clinic there. And I wanted to let you know what the Affordable Care Act has meant to us and the clinic there. The Affordable Care Act has let our clinic practice as a comprehensive model. Because of the Medicaid expansion, we've been able not only to get excellent medical care, we've also been able to expand our services to dental, to vision, and to the behavioral health realm, which is something for me that's very foreign to have a behavioral health person in our clinic, so they don't have to be referred out and wait 6 months for their so they can be seen for their depression. This has helped us tailor our care for each patient and their needs. We just don't focus on the illness. We focus on the whole person, the whole patient care. The Affordable Care Act has offered us insight to be a true patient-centered medical home. Serve the People was awarded this in 2015. Patients want to truly be cared for by their providers. We've created a very culturally sensitive environment in our clinic. Through the patient-centered medical home, we also offer, it's not just the doctor-patient relationship anymore, it's actually made us expand to doctors, nurses, nurse practitioners, physician assistants, nutritionists, social workers, and care coordinators. So this is now a whole team effort. And for us, for myself, even beforehand, when I was doing this without all that, it felt like a sinking ship. Now you feel like there's a support system in line. It's truly patient-centered. The Affordable Care Act has helped us start innovative programs, such as the Health Scholars Program, which I see a lot of them here. As you were talking about the pipeline, that's where it is right there. They're Orange County students, college students, and they're the next generation of providers in training. They're actually, the passion for serving the underserved is second to none. Our community health centers serve as a training place for them. So we can go ahead and they're facilitators there for our diabetes group visits, for our weight management, and they're also healthcare team navigators as well. Without the Health Scholar students there, our group medical visits, our health coaching, and our patient navigation doesn't get done. The Affordable Care Act has also helped us with group medical visits. Now, this is such an easy concept. 8 to 12 patients in a room talking about their disease, talking about things that go on. I always joke around, but it's true. I say, I could read about this stuff. I could read about diabetes, but I've never learned more than when I'm in a group with my patients and they're telling me, this is why I don't take this medication. This is why I don't do this. This is why, And then having that problem be solved, not by me, by their peers. And we can actually follow through with that. And we have the capacity now to follow through with self-care plans. In the beginning of the year, we had a patient that came in, talk about her struggles about diabetes. She felt frustrated. She felt alone. She even said, you know what? If God wants to take me like this, let her take me. That's fine. Let him take me. I don't care. Because if I'm supposed to die, I'm supposed to die. Our group visit, you just saw the magic happen there. You just saw the patients come to her struggles, come to understand her. She felt heard. And I'll tell you what, to this day, she's been hospitalized a few times before with diabetic ketoacidosis. So she's been on that door. And now to have her not ever miss a group medical visit, not ever miss an appointment, for us, that's the magic. That's when that happens. So these are the stories that the Affordable Care Act has created. How are we affording all this? Or how do we afford all this? How do we, now all of a sudden we come from like not having the resources to now this. Well, as an FQHC, we receive additional fundings for that allows us to become a more comprehensive healthcare delivery model. Medicaid funding is our bread and butter. It makes up 70% of our healthcare budgets. It keeps the lights on. It helps pay for preventative services that our patients couldn't afford otherwise. It keeps them out of the emergency room. I was around, like I said, when the Affordable Care Act wasn't around, and it has made the world of a difference. No longer do I have to wait for my patients' kidneys to fully fail to send them to the emergency room so they can have emergency insurance. No longer does that happen. I don't want to go back to the way it was before. And in closing, Serve the People has increased exponentially since implementing the Affordable Care Act. I can't see medicine without it. We excel at bettering the health outcomes of our patients and to do so in a manner that is tailored and sensitive, culturally sensitive to our patients' needs. But we're not alone. Here to speak on the needs of the LGBTQ health and community is Anders Wallen.
Hello, I'm a first-year medical student at UC Irvine. I'm one of the co-presidents of Equality, which is a student organization at the School of Medicine that aims to foster a positive space for LGBTQ identified individuals and allies at the medical school and in the broader healthcare system. Among our goals are improving health access and outcomes for LGBTQ patients, also a goal of Healthy People 2020. Most medical schools across the country, including UCI, provide only a few hours of LGBTQ competency training to students. Providers and staff get even less. As a result, most healthcare professionals do not have adequate training to fully address LGBTQ health needs. Many people are not aware of the serious blow society deals to LGBTQ health. LGBTQ individuals face health disparities linked to societal stigma and discrimination. For example, here are some statistics. LGBTQ people earn less than others with the same level of education. A disproportionate number of LGBTQ adults have been homeless, and across the country, 40% of homeless youth are LGBT. Discrimination against LGBTQ people has been associated with high rates of mental health disorders, substance abuse, and suicide. 40% of transgender adults report having attempted suicide sometime in their life, 92% before the age of 25. LGBT youth who come from highly rejecting families are 8.4 times as likely to have attempted suicide than LGBT youth who come from families who accept them for who they are. Experiences of violence and victimization are frequent for LGBT individuals and have long-lasting effects on the individual and the community. Trans women of color are murdered at a higher rate than any other group in the country. Gay men are at higher risk for HIV and other STDs, especially among communities of color. Gay men are also increased at increased risk of cardiovascular disease from HIV medications and increased risk for cancer. Lesbian women in some areas are more likely to suffer from diabetes, heart disease, osteoarthritis, and fatal breast cancer. Bisexual women are more likely to have eating disorders and experience intimate partner violence. Transgender patients have some of the highest health disparities. Transgender people are frequently unsafe in public restrooms, and urinary tract infections are not uncommon for those who drink less water just so they can make it through the day safely. 19% of transgender patients report being outright refused medical care because of their transgender status. It is estimated that by 2050, one in every 13 elders will be LGBT. Elderly LGBT individuals face additional barriers to health because of isolation and a lack of social services and culturally competent providers. Studies show that ignorance and prejudice from health professionals prevents LGBTQ patients from accessing and seeking out routine medical care. 50% of transgender patients report having to teach their providers about transgender medical care. LGBTQ individuals encompass all races, cultures, religions, and social classes. Given that LGBTQ individuals represent 6 to 8% of the population, this means roughly 250,000 of Orange County residents are at increased risk for these poor health outcomes. The LGBTQ community is uniquely disadvantaged when it comes to health care, but this community benefits greatly from health centers that sensitively and competently tailor care to their disparities. To address this, Equality has worked in partnership with the university and the LGBT Center of Orange County to create and lead LGBTQ competency trainings for students, providers, and front office staff in our community health centers in order to help care for the increased numbers of LGBTQ patients that now have health insurance through the ACA and Medicaid Expansion. Our country needs more doctors that are willing to engage in this kind of care. Health center programs such as the National Health Service Corps and teaching health centers engage physicians in community-based trainings as well as recruit newly graduated health professionals. One day, I hope to provide care to the LGBTQ population in a center such as these. It is my hope that with continued Medicaid expansion, these cost-effective health centers will not only be still around, but will have expanded to further resolve the health disparities these communities continue to face.
So my name is Lynn Hunt. I'm a long-time Orange County pediatrician. I've practiced primarily at the Family Health Center in Santa Ana. I'm a clinical faculty at UCI, as well as national chair for LGBT health and wellness at the American Academy of Pediatrics. And as a pediatrician, I obviously know firsthand the incredible importance of Medicaid and CHIP because they directly serve over 50% of California children. But today, I want to join Anders and focus my remarks on some of the most vulnerable patients we have, which are the LGBTQ folks. You've already heard a long list of health disparities encountered, but I want to mention that the ACA and Medicaid expansion have directly impacted sexual and gender minorities in a really positive way. Because the prevalence of poverty in LGBT communities is increased, especially among transgender folks and LGBT people of color, Medicaid is a critical program for the health and well-being of our patients. But health coverage for all LGBT adults has increased substantially since the initiation of the ACA. And there are many communities besides the LGBT that are impacted by HIV. But Medicaid expansion is equally important for people with HIV. Similar to what Dr. Angulo said about diabetes, under Medicaid's previous categorical eligibility requirements, low-income individuals with HIV frequently weren't eligible for Medicaid until their disease had progressed to the point of full-blown AIDS, and then they were eligible as a disabled person. The ACA's Medicaid Expansion eliminates this barrier to timely and effective HIV treatment by allowing all individuals with incomes up to 138% of the federal poverty level to qualify for Medicaid coverage regardless of their disability status. And it isn't just the expansion of eligibility or the affordability of ACA, but also the protections built into these programs that are crucial for our patients. Individuals can no longer be denied insurance due to pre-existing conditions, and this can mean mental health conditions, just being trans, or HIV status. Prior to the passage of the ACA, 59% of low and middle income transgender individuals didn't have insurance, not because they didn't want it, but because being transgender was considered a pre-existing condition. What's more, Section 1557's sex-based non-discrimination protections explicitly protect transgender and gender non-conforming individuals, and also protect gay, lesbian, bisexual individuals and their families from discrimination on the basis of sex stereotypes. You'll hear some more about the importance of healthcare centers and Medicaid dollars have in helping to train tomorrow's community health providers. But I do want to highlight the reciprocity of this relationship, again, such as the training sessions that Anders is spearheading. Our idealistic, bright, and committed trainees themselves are enhancing the healthcare centers and the care provided. And as you can tell from some of the young people here today. And to close, I'd just like Anders to share, in a HIPAA-compliant way, a profile of a typical patient we have in Orange County.
So AJ is a 27-year-old who identifies as a transgender man. He had a part-time job and couldn't afford medical insurance before the ACA. His family wasn't affirming of his transgender identity, and so he was on his own for his own healthcare needs. He desperately needed to transition, but couldn't afford a therapist, an endocrinologist, or out-of-pocket costs for testosterone, and lab tests as well. He obtained testosterone online, but had no way to check his blood levels. Meanwhile, he also suffered from untreated severe anxiety and depression. He ended up unable to work or attend school. Once the ACA was solidified, he was able to obtain insurance and see a physician and therapist at a community health center. It was then that he discovered that his blood levels weren't in normal range. He was taking too much testosterone and his hormones were dangerously out of balance. After a year of actual physician management and therapy, AJ is happy, healthy, his lab's in normal range, and he is able to work and attend school. And now we want to talk about specialty drugs. Specialty drugs are expensive, and many providers look to provide the most cost-effective solutions for patients. Here to highlight the 340B drug price program is Matt Chinchuli from the Center for Inherited Blood Disorders.
Thank you. And he pronounced my last name perfectly. So I'm Matt Chinchuli. I'm from the Center for Inherited Blood Disorders. We are a nonprofit specialty care center located in Orange, California. And it's a privilege to be here. And as Isabel mentioned, we're a proud member of the Coalition of Orange County Community Clinics. So what I want to talk to you about today is a program that's in jeopardy, and it's the 340B drug discount program. Many people have never even heard of the 340B drug discount program because not all centers utilize it. So the program was actually founded in 1992, and historically, and even to current day, it's pretty much kind of enjoyed bipartisan support from both sides. So the goal of this was to protect clinics like FQHCs, like ours, from massive drug price increases. So the aim of the actual program is to stretch scarce federal resources as far as possible, reach in more eligible patients, and provide in more comprehensive services. So some centers that qualify include federally qualified health centers, lookalikes, Ryan White HIV/AIDS programs, children's hospitals, disproportionate share hospitals, freestanding cancer centers, and centers like ours, hemophilia treatment centers. And a lot of these centers became eligible because of the ACA. So how this program works, it's a little complicated, but essentially these covered entities, these clinics, have access to drug discounts with the stipulation that money raised in this program must be reinvested back into patient care. So it's one of the few things that's a win-win-win-win situation, and it's extremely critical. So the pharmaceutical companies, they get government incentives to participate. Clinics, they make more money. Patients get better care. Regardless of insurance, they can come to us and not have to worry about paying for it because this program supports that. And it works out good for the government too because these patients are getting better care and they're not ending up in the ER. So it's one of the kind of full circle programs that I think is really critical and important. So I want to just tell you a little bit about how CIBD uses their funds. We've really invested into the comprehensive care model. So when a patient comes to our clinic, they see a physician, they see a nurse, they see a physical therapist, they see a social worker, psychologist, pharmacist, all these people under one roof at the same time. The patients that we serve typically have genetic disorders, lifelong, so we start them young by educating them, having them take care of their own health, and it's worked out extremely, extremely well. The patients love coming to us. We love having the opportunity to have that comprehensive model being offered to them. So our Hemophilia Treatment Center and others around the country have been collecting data since the 340B program got started. What we've seen, 40% reduction in mortality rate among our patients, which is huge. 40% fewer hospitalizations, decreased school and work absenteeism, higher high school graduation rates, increased employment rates, increased quality of life, and now with the program set up, overall lower healthcare costs because these patients are expensive to take care of. So there's a little bit of kind of transition, and I guess the word would be 340B is under a little bit of scrutiny right now. So it's important to have our voices heard and say how beneficial it's been to us and a lot of the other FQHCs in the room. So with the repeal of, if the ACA was actually repealed, a lot of these covered entities would no longer be covered. They would not have access to this program. They've also proposed a decreased reimbursement rate for these 340B drugs. If that happens, it's just being taken away from what we can offer to our patients. The final thing that they've even talked about is the elimination of the 340B program. If this happened, there is no way we could keep our doors open. This is our lifeblood. This is everything that we have is based on this program. We spend 2 to 3 hours with each of our patients, and if we don't have the funds coming from pharmacy, we have to close. If that happens, you're going to see increase in unemployment among healthcare workers in Orange County. Our patients are going to end up where we don't want them, back in the ER. They're not going to be compliant with their medications. They're probably going to need more medications, and overall healthcare costs are going to go right back up. So just want your support and support in this very important program. I know it's done a lot for the FQHCs. Our center is always happy to help with other programs wanting to get this up and running, but it's really critical moving forward. So thank you, and I will now pass it off to Chapman University, and they will be talking about workforce development.
All right, well, good morning, and I just want to say thank you to the coalition for putting this together and inviting us. They're a great partner. So we're a new physician assistant program. We just started bringing in our students this January. It's a class of 25 that will go up to 50 over the next couple of years. It's a 2-year program. It's a master's program. You know, we're Orange County. Our mission was based on things that are pertinent and relevant to this county. We want to, take care of the underserved. We want patient-centered care. We want, culturally diverse education and understanding of healthcare. So in that sense, it was an easy partnership with the coalition and their mission and how they're doing things. So I'm the associate program director. I'm not the full boss. I'm second in charge. But so you know what that means, right? So with that, right, do a lot of the work, right? Do a lot of the legwork. But I want to give Vivian an opportunity to talk. But what I want to do is make sure that 2 things are vividly stated here. Is that we want to continue to have the funding of the National Health Service Corps, and the relevance to that is to get young people So we know that in order for people to work in these communities, they need to have an incentive. There's competition out there. So we were making a joke before, and nothing against dermatologists or whoever, but there's a strong demand for healthcare providers. PAs are one of those, right? PAs, nurse practitioners, and doctors. They can go work anywhere. The world is their oyster. How do we get them to work in these communities and areas? We give them scholarships and fundings and opportunity. So there's a few people that can do that and help incentivize things to get them there. Now, we know that if they come from that community, a lot of times they'll go back and work there. We also know that if we incentivize it, we can get them to go back work in those communities because they now have a better understanding of that community and group, and they'll feel more inclined to work in that area just based on their experience. So what else? And I want to ask that we continue to invest in the teaching health centers. So these clinics that are working off pennies and dimes and working hard, and every provider in the clinic is working very hard to take care of their patients. We have our students in there so that there's some incentivization to the clinic and for the students to have that opportunity to see the patients in that environment. Patient-centered care, culturally diverse groups of patients are so important. This is a part of our population, but like I said, there's competition. So, in our end, I'm deeply seated in family medicine, and that's where my love of care is. So I certainly push our students in that direction. I'll make a couple more comments here. Today, more than 11 million people are cared for by the National Health Service Corps. More than half of these clinicians serve in health centers. Many health centers still cannot gain access to these providers due to funding. 2015 analysis by the American Association of Medical Colleges estimated that the United States may face a shortage of up to 90,000 physicians. So we'll say healthcare providers, PAs, MDs, nurse practitioners, by 2025. It's like growth is exponential right now. There's a lot of opportunity for healthcare providers, and there's a big shortage. Obviously, the Affordable Care Act, bringing care to all people, has helped get that to where we'll help make that a problem, which we like. Shortages in primary care projected to be up by 31,000. More than 95% of health centers say they currently have at least one current staff vacancy. Health centers themselves estimate that its staffing needs were met. Collectively, they could be serving an additional 2 million patients. Most health centers are involved in health professions education or residency training, but much smaller number of designated teaching health centers, a promising model that has been putting training in the community. Many health centers are interested in becoming teaching health centers, but they have been hesitant giving funding uncertainty. So if you don't know if you're going to have the dollars to do that, where's your priority going to fall? You got to take care of your patients, right? So we've got lots of people that are precepting and taking care of students, spending extra time in their days to make sure that these students are ready to take care of diverse groups of patients. The challenge, as with health center funding, without action by Congress, funding for the National Health Service Corps and teaching health centers will expire. This would immediately jeopardize the care provided by more than 10,000 clinicians today and reverse progress on a bipartisan move toward community-based training. I got lots of good things to say. Vivian is a very intelligent young lady who is local. She's a family of diversity. I'd like you to hear a few words from her on her perspective, and then we'll move forward from there. So Vivian Acevedo, please go forward and speak a few words.
Okay. According to the United States Department of Labor, employment of PAs is expected to grow 30% from 2014 to 2024. This is much faster than the average for all occupations. Moreover, as the demand for healthcare service grows, PAs will be needed to provide care to patients. The National Health Service Corps and the Teaching Health Centers program are very beneficial to students because it not only guarantees students who are in the program a job after graduation, but it also benefits to the community. Furthermore, it takes away the burden of loans to students and gives them the opportunity to work in underserved communities. As a PA student, I would like to see Congress take action and fund National Health Service Corps and Teaching Health Center programs that expire this September. Lack of funding will affect the care of more than 11 million people in addition to students' education of community-based training. By investing in these health centers, it provides an opportunity for students to have a unique experience. Students will have the chance to treat real people with real situations. Students will have to learn different treatment options for patients that can't afford medications or to change their organic-based diet. Furthermore, this experience will contribute to the development of future healthcare providers and have an impact on their future patients. Now I'll share with you a personal story of why I chose to become a PA. Preventative medicine is frequently the subject of intense debate with patients, but all too often taken too lightly until it's too late. In 2014, my 42-year-old father suffered from a minor stroke and my life changed in an instant. I garnered a new perspective toward medicine, which ultimately strengthened my drive to pursue a career as a physician assistant. After many diagnostic exams, physicians determined that my father's stroke was caused by undiagnosed and untreated hypertension. My father had not seen his primary care physician in 2 years, which led me to believe that if he had seen his primary care physician annually and his blood pressure could have been managed, the stroke that risked his life could have been prevented. This palpable understanding of preventive medicine and the critical role of primary care has led me to want to be a physician assistant. I want to be able to address my community's needs, educate patients about preventable diseases, and become a healthcare advocate for my patients. I'm passionate about working with underserved populations because I have witnessed for myself the disproportionate effect chronic illnesses can have on children from underserved communities. Volunteering in a pulmonary clinic, I had the opportunity to care for medically underserved populations of Santa Ana and Costa Mesa. As a volunteer, I roomed patients and took vitals for newborns, children, teenagers, and adolescents. After the nurses completed the pulmonary function test, I would come in with the physicians to translate the results, as most of the patients were Spanish speakers from lower income families. In addition to translating for the physician, I also assisted the nurses by educating patients and families about asthma. I taught patients the importance of using chambers with their inhaler and methods of having an asthma-free environment. Many of the families could not afford the equipment we recommended, so we provided discounts for them. Patients lived in areas polluted by smog, houses where family members smoked, and within walls that had mold, all which made the patient's symptoms worse. These experiences taught me the importance of educating patients about preventative measures, something that I plan to do as a future plays on patients' health. Children at such a young age were burdened with diagnoses of obesity and diabetes, in addition to having childhood asthma. We saw that there was a clear difference in the health status of children from families of higher socioeconomic status compared to children from low-income families. These experiences helped me realize my motivation to help underserved populations. I plan on applying to the National Health Service Corps Loan Repayment Program because I'm passionate about primary care and helping underserved communities. I was a mentor for Higher Ground, a nonprofit organization that provides nutrition and enrichment programs for youth in at-risk communities in Anaheim, where I witnessed children again suffering from chronic illnesses. Many of these children in these communities were obese and diabetic as a result of their social economic status. As a mentor for these children, I had the opportunity to interact with their families and build personal relationships. For many of these children, the snack and dinner we provide are their only meals for the day. As a result, I saw how hunger and lack of nourishment affects the children's psychological and physical health, which can be devastating. I carry these experiences with me daily because being a part of the community motivates me to be more than just a mentor for these children. Once clinically licensed, I want to be able to treat the kinds of acute and chronic illnesses that disproportionately affect underserved communities like the one I worked in.
Thank you, Vivian. So transition back to Health Center perspective, please help me welcome Fernando Rules. He's a PA from the Central City Health Center.
Hi. My name is Fernando Bull, and I'm a physician assistant with Central Cities Community Health Centers. And I became a PA in 2002 and began working in private practice. In about 2009, I started working as a locum, and I got a chance to travel throughout the Central Valley working in a lot of different community health centers. And that's really where I felt like I developed a passion for the underserved. I also got a chance up there to work with migrant seasonal farm workers, and that really opened up my eyes as well. Began working for Central Cities in 2013, and the main reason I started working there was because they have a community programs department. And one of the neat things is we have a mobile unit where we're able to go out to the community centers and out to different schools, different locations and help treat the underserved. We come here twice a month on Wednesdays and see patients here in the Delhi parking lot. The mission of community health centers is to serve the underserved and provide service to all, regardless of their ability to pay. And I'm grateful to be part of the community health center system. It definitely helps me remember why I chose to become a provider in the first place. The problem is that we really need more practitioners, more providers. As some have talked about, we've seen a huge increase in the patient population with the ACA. I believe in Orange County about a 41% increase in the patients. But if you look at the increase of providers for those same patients, it's probably under 30%, I believe. And what I've seen is in the clinic where I'm at is an increased demand on our providers to see more and more patients. But as a community health center, we're also held to a much higher standard of quality of care, and it's becoming more and more difficult from what I've seen. It's also, what I've also seen is increased wait time for our patients. Not to be negative, but these are things that have come along with this increased insured population. Sometimes I've seen patients waiting 3, even 4 hours to be seen in our clinics. So we need improved reimbursement. We need I'll move on. I'll talk about that in a minute. Sorry. Also wanted to